Now, next presentation by the Dr. Nikita, Ahuja. She will be talking on the necrotizing scleritis in granulomatosis with polyangiitis.
Is Dr. Diksha here?
There, Dr. Diksha is also there, so she can load her presentation on the next podium.
Or Dr. Swati Sharma? No.
I think is the last presenter. Okay, please.
Good evening everyone, I am Dr. Nikita Ahuja from AIIMS Bhopal and my case is necrotizing scleritis in GPA, management and outcome challenges. So I would be presenting a case of 44-year-old Asian female with chief complaints of left eye pain on and off since 1.5 years, along with redness in the left eye since 1.5 years with loss of vision since 3 weeks. She was a known case of left eye scleritis for 1.5 years with on and off systemic and topical steroid therapy. She had pain in left eye since 1.5 years, which was gradual in onset, progressive in nature. It was throbbing type, aggravated by ocular movements and radiated to temple and jaw areas, associated with photophobia and redness. She recently developed diminution of vision in the left eye for the past 3 weeks, which was insidious in onset and progressively worsening. It was associated with multiple episodes of fever, shortness of breath, and on ENT evaluation, she had left ear pain, and on ENT evaluation, it revealed central tympanic membrane perforation. Other than GPA, she is also known case of hypothyroidism since 2 years and primary biliary cirrhosis. There was no history of epistaxis, sinusitis, arthritis, weight loss, malar rash, or seizures. And she was already on and off therapy, both steroid and both oral and intravenous steroids, along with topical, which was going on since past 1.5 years, and also on thyroxine. The family history was negative for any autoimmune disease and any infectious disease like TB. So on local examination, when the patient presented to us, the vision was PL positive and PR inaccurate, and extraocular movements were reduced in all the quadrants and painful. As we can see here at 11 o'clock, there is a necrotic scleritis foci with perilimbal corneal perforation along with uveal tissue prolapse from 9 to 11 o'clock position and infiltrates overhanging with overhanging margins at 8 to 1 o'clock position. So on further examination, the patient was reluctant for fundus examination, so we did a B scan which showed diffuse chorioretinal thickening with T sign indicating posterior scleritis along with exudative retinal and shallow choroidal detachment. And other eye examination was within normal limit. So we came to the provisional diagnosis of necrotizing scleritis with limbal perforation with exudative retinal and shallow choroidal detachment. We subjected the patient for systemic examinations like chest X-ray, which revealed multiple bilateral cavitary lesions. CRP was raised and ANCA came positive with IG raised. On PET scan, there were hypermetabolic lesions noted around the left intraorbital regions with lateral surface of the left lobe. On management, we put the patient on IVMP 1 gram for 3 days, after which we shifted them to oral prednisolone 1 mg per kg along with appropriate tapering, followed by injection cyclophosphamide 1 gram, which were 2 doses 10 days apart, and the third dose was 2 weeks later, along with mycophenolate and supracal. Locally, she was put on topical steroids and cycloplegics along with antibiotics and anti-glaucoma drugs. In alliance with pulmonary and rheumatology consultation, patient was regularly followed up on the above mentioned treatment. So after 3 cycles of cyclophosphamide, the vision improved significantly with decreased lid edema and healed necrotic plaque supranasally, as we can see, with decreased limbal infiltrates with PUK sequelae. And after on the B scan, the retinal detachment was resolved. On further follow-up after 6 cycles of cyclophosphamide and the current picture, the patient shows the necrotic scleritis foci was resolved with overlying non-perfused episclera and conjunctiva eventually perfusing over time. There was resolution of perilimbal infiltrate as well. For further management, with discussion with rheumatology and pulmonology, we have the patient to start on biologicals such as rituximab. It could have been complicated, like we could see that PUK has occurred already. So to summarize, even after 6 cycles of cyclophosphamide, patient disease activity still persisted. So for further management, rituximab could be a desirable approach. Thank you.
Is that a retinal detachment or a choroidal, subchoroidal fluid got dissolved?
There was inflammatory fluid along with exudative retinal detachment and shallow choroidal detachment.
In the previous B scan, the patient had this
Yes.
thing. Okay. It's indeed a very rare disease, as well as it's very difficult to pick up, do the early diagnosis in these cases, and it's very well picked up by you people and well managed. And rituximab is the treatment of choice.
Yes, she is on follow-up with us now, and we are planning to give rituximab, start rituximab after rheumatology consultation.
And her age was 42. Huh?
44 years.
44. Thank you.
Okay. So thank you for the all presenters who presented today's all these interesting cases and all. So that's all from our side. Yeah.